This seminar is about how to effectively diagnose and treat neonatal shock. We are going to talk about cardiogenic shock and septic shock. Shock is a syndrome that results from inadequate oxygen delivery to meet the metabolic demands. That means oxygen delivery is less than oxygen consumption. Untreated shock leads to metabolic acidosis, organ dysfunction, and death. Oxygen delivery, again, is because of cardiac output and arterial oxygen content. Cardiac output is a product of heart rate and stroke volume. Stroke volume, again, determined by preload, afterload, and contractility. Arterial oxygen content is the oxygen carried by the hemoglobin and oxygen dissolved in plasma. But in all practical purposes, in the absence of special circumstances, most of the time, oxygen content of the hemoglobin determines arterial oxygen content. Other concept to remember is oxygen consumption is equal to oxygen delivery and oxygen extraction ratio. That means oxygen delivery may be good, but the oxygen extraction is so high, still makes it the oxygen consumption is excess of oxygen delivery. There are three groups of patients you can see when you use oxygen extraction as the important principle. There are conditions where oxygen extraction is low, still the patient may be in shock, like cyanide toxicity, or in patients in ICU, those who are undergoing severe sedation or deep sedation or paralysis, their oxygen extraction ratio is lower. Another group is called high oxygen extraction and low oxygen delivery. The mnemonics you use is OCRAP: oxygen, hemoglobin, contractility, rate, rhythm, afterload, and preload. Any of these abnormalities can affect oxygen delivery to the patient or shock and perfusion due to other reasons. Another group, high oxygen extraction and high oxygen consumption. That happens in patients with fever, inflammation, hypermetabolism, exercise, shivering, and increased work of breathing. Let's move on to cardiogenic shock. There are lots of non-specific signs that may indicate cardiac causes of hypotension. Those are tachycardia, tachypnea, cyanosis, oliguria, restlessness, and altered mental status. There are three distinct pathophysiologic reasons why the neonates with underlying heart disease have shock-like state. One, left-sided obstructive lesions. Number two, right-sided obstructive lesions. And third is two parallel circuits. They are not connected to each other. The causes of left-sided obstructive lesions are coarctation of aorta, interrupted aortic arch, and hypoplastic left heart syndrome. The right-sided obstructive lesions, pulmonary atresia, and tricuspid atresia. The parallel systemic and pulmonary circuits without any connection that you see in transposition of great vessels with intact ventricular septum. Hypoplastic left heart syndrome. This is underdeveloped left side of the heart. In this hypoplastic left heart, you may see aortic and mitral valve stenosis or atresia or hyperplasia of the left ventricle and ascending aorta. The incidence of this syndrome 0.016 to 0.036 of all live births. This slide shows normal heart and hypoplastic left heart. I just wanted to walk you through how the circulation happens in normal heart. Normally, the right atrium receives venous blood from superior vena cava and IVC. The deoxygenated blood comes to the right atrium, finally in right ventricle. Then the deoxygenated blood is ejected into the pulmonary circulation where it gets oxygenated. So oxygenated blood returns back to the left atrium and to left ventricle. That oxygenated blood then ejected into the systemic circulations via aorta. In patients with hypoplastic left heart syndrome, right atrium receives venous blood from both SVC and IVC, comes to right ventricle, and it is pushed back into the pulmonary circulation. Then what happens afterwards? The oxygenated blood returns back to the left atrium. Since there is no left ventricle, it again passes through the foramen ovale to the right atrium, then right ventricle, again projected into the pulmonary trunk. The systemic circulation receives blood through the ductus arteriosus. The ductus arteriosus is usually closed during the first week of life, then the problem comes. So these patients born at term appears very healthy, and the closure of the ductus arteriosus causes hypoxemia, acidosis, and shock. Auscultation may not reveal any murmur. You can listen single second heart sound. How do you treat? Maintain the ductus arteriosus by starting prostaglandin E1 infusion. The definite way to treat hypoplastic left heart syndrome either by primary cardiac transplantation or palliative surgeries. The palliative surgeries are most commonly used because when you do a transplantation, it has its own issues with being transplanted. The palliative surgeries, again, for hypoplastic left heart syndrome involves 3 stages. The first one, called Norwood stage 1 at birth. Second, Glenn shunt, that is done at the age of 6 to 8 months of age. And third is modified Fontan procedure. It's usually done between 18 months to 4 years of age. This is the classic stage 1 Norwood. In this one, the hypoplastic arch is reconstructed. We call new aorta has been created. Second, close the PDA. Third, create a shunt between systemic circulation to pulmonary circulations. Based on the size of the shunt, it allows how good the pulmonary blood flow should be. So you need to be very meticulous what size of the shunt you create. If you do a bigger shunt, it is going to flood the pulmonary circulation because pulmonary vascular resistance is very low. So these are the 3 components of classic Norwood stage 1. And there is some Sano modification, the place where I trained. They do Sano modification. This one, new aortic arch has been constructed, PDA has been separated, and instead of doing a shunt from systemic to pulmonary circulation, they create RVPA conduit called Sano modification that determines the blood flow to the pulmonary circulation. The second stage is called bidirectional Glenn, where the venous SVC venous blood directly connected to the pulmonary trunk. As a result, the SVC venous blood flow goes into pulmonary circulation, get oxygenated, come to the left atrium, and then through the foramen ovale come to right ventricle that pushes the blood into the systemic circulation. The third procedure is called stage 3 extracardiac fenestrated Fontan. In this one, both SVC and IVC are connected to the pulmonary trunk. The whole venous blood system goes into the pulmonary circulation. Then it gets oxygenated, comes into the left atrium, through the right atrium, come to right ventricle, and eject the blood to the systemic circulation. And the thing is different from normal heart is, number one, the whole blood volume is handled by one single ventricle. It's called single ventricle physiology. Second, the venous return to the pulmonary circulation does not have the pulsatile flow typically done by the heart. It is a passive flow from the venous system to the pulmonary circulation, so it has its own consequences and side effects. The second the condition we are going to discuss is pulmonary atresia with intact ventricular system. It's characterized by atresia of the pulmonary valve. The incidence is about 1% of all congenital heart disease. This is a normal heart, which we already discussed. In pulmonary atresia with the intact system, very similar, but it is the right side of the heart. Here, the pulmonary trunk is atretic, either because of valvular stenosis or the whole trunk is atretic, and the right ventricle is very miniature version. And what happens is right atrium receives blood flow from SVC and IVC. Then blood flow happens from right atrium to left atrium. That mix with blood flow from pulmonary circulation. It comes to left ventricle and ejects blood through the aorta to the systemic circulation. How does the pulmonary circulation receive blood? Through the ductus arteriosus. It is a reversal of hypoplastic left heart syndrome that we have just discussed. On examination, these patients will have single, loud second heart sound. Sometimes you can hear continuous murmur. Often there are no murmurs or audible. Chest X-ray shows oligemic lung. EKG will show tall peaked P wave suggesting atrial enlargement. Again, the treatment is immediate PGE1 infusion because patents of the ductus arteriosus is very important to feed the pulmonary circulation. If the right ventricle cavity is well formed, simple pulmonary valvotomy alone enough. It opens up circulation to the pulmons. If the right ventricle is too miniature, that means it's very underdeveloped, then Glenn procedure followed by modified Fontaine procedures like what we have done in hypoplast left heart syndrome will do for these patients too. Third group is TGA with intact ventricular system, where the two parallel circulations without any communication between them. It is responsible for 5% of all congenital heart disease and 10% of all neonatal congenital heart disease with cyanosis. X-ray has a typical appearance of egg-on string appearance. EKG initially may be normal. Over time it will show right ventricle hypertrophy and right atrial enlargement. This is how this heart looks. The venous blood comes to the right atrium, right ventricle. It ejects blood into aorta because aorta arising from the right ventricle. Left ventricle receives blood from pulmonary circulation. It circulates into that one. In the absence of ASD, VSD, or PDA, these patients will succumb to death. The treatment is PGE1 infusion. And to keep, these are all called ductal dependent lesions. Without ductus, these patients may not survive. Immediately after opening up the ductus, septostomy, easy way to rescue this patient. Nowadays, they undergo arterial switch operation that is very rewarding in a long term. Let's start. So how does prostaglandin E1 works? It dilates the ductus smooth muscle so that it remains open. The blood flow can happen either from systemic to pulmonary circulation or pulmonary to the systemic circulations based on the underlying condition. The initial dose, we typically do 0.05 to 0.1 mics per kg per minute. Then titrate the dose to keep the saturation 80 to 85. Do not shoot for higher oxygen saturation. That means increased pulmonary blood flow that will cause pulmonary edema and eventually cardiac failure. The side effects of prostaglandin E1 infusions one should remember. The most common being flushing, apnea, and fever. Most of these kids will get intubated before or while you are starting PGE1 to avoid catastrophic respiratory arrest. It can also cause bradycardia, tachycardia, hypertension, hypotension, seizure, hypokalemia, and diarrhea, etc. Other medications most commonly used in neonatal area, the number one being dopamine. Dopamine has three effects based on the dosage used. Up to 5 mics per kick per minute, it acts on dopamine 1 and dopamine 2 receptors. It predominantly has renal vasodilation. Between the doses of 5 to 10 mics per kick per minute, it has positive inotropic and chronotropic effect, mostly to augment myocardial contractility. When the dose exceeds 10 mics per kick per minute, the action will become predominantly alpha-adrenergic that increases systemic vascular resistance as well as pulmonary vascular resistance. One has to be very aware of increase in pulmonary vascular resistance in neonates with congenital heart disease and also in neonatal septic shock. The second most common drug used in neonates is dobutamine. Dobutamine predominantly has an effect on beta 1 and beta 2 receptors. The dose used is 2.5 to 10 mics per kick per minute, and it's often used along with dopamine to help cardiac dysfunction, and also it is used to reduce systemic vascular resistance, and also it helps to reduce pulmonary vascular resistance in patients with pulmonary hypertension and right ventricular dysfunction. The third medicine often used is epinephrine. It is based on the dose, the effect varies. With a dose of 0.01 to 0.1 mics per kick per minute, it's predominantly beta 1 and beta 2 effects. So you will see more of inotropic actions, that means improving cardiac contractility and effect on systemic vascular resistance. When the dose exceeds more than 0.1 mics per kick per minute, the action will be predominantly alpha effects. That means it will increase systemic vascular resistance. And also one should remember higher doses associated with increased plasma glucose and increased plasma lactate. Norepinephrine, when compared to adults and pediatric patients, it is less commonly used in neonates because we do not have enough data to support the use of norepinephrine in neonates. As you all know, it predominantly works on alpha 1 and alpha 2 receptors. As a result, it increases systemic vascular resistance and also increases pulmonary vascular resistance. Sometimes it's used in catecholamine refractory shock, and sometimes in pulmonary hypertension, post-cardiac surgery, and other conditions after dopamine, dobutamine, epinephrine. Mildenone, it's different medication. It is used widely in post-cardiac surgery patients. It acts through phosphodiesterase. It increases intracellular cyclic AMP. Thus, it causes inotropic action and also lusiotropic action. Thereby, it causes relaxation of the ventricle, thus improve the diastolic dysfunction in the heart. The dose used is 0.25 to 0.75 mics per kick per hour and is very commonly used in post-cardiac surgery, in patients with pulmonary hypertension, and also prevention of left ventricular outflow, low outflow syndromes, and after PD ligations. And you can see tachycardia and hypotensions, especially when you use mildenone. Vasopressin acts through V1 receptors and V2 receptors. It is used in catecholamine and steroid refractory vasodilatory shock. It can cause tachyarrhythmias, hyponatremia, transient thrombocytopenia, and liver necrosis. The dose is 0.00001 to 0.003 units per kg per minute. Terlipressin is prodrug of vasopressin. The dose is 5 to 20. Actions are similar to vasopressin, but it causes cardiac splanchnic and digital ischemia. It's used only in catecholamine refractory shock. In the latest guidelines for adults, they are not suggesting to use terlipressin. The next drug is levosimendan. It is a calcium sensitizer. It has an inotropic action and also vasodilatory action. Its infusion 0.2 over 24 hours. It is useful in patients with severe refractory warm septic shock and also in patients with pulmonary hypertension with cardiac dysfunction. The side effects are tachycardia, arrhythmias, hypotension, potentially recurring interventions. Well tolerated, but I need to emphasize these current guidelines in adult septic shock. They recommend against using levosimendan because it did not have any mortality benefit when compared to other vasoactive agents. Hydrocortisone, it's a hormone. It helps in improving the capillary integrity. Along with in catecholamine resistant shock, the hydrocortisone definitely improve the hemodynamics. The initial dose is 1 to 2 mg per kilogram, followed by 0.5 to 1 mg every 8 to 12 hours. It is an adjuvant therapy in refractory cases and pulmonary hypertension resistant to nitric oxide and other inotropes. The side effects are transient hyperglycemia, hypertension, and spontaneous intestinal perforations, and rare myocardial hypertrophy. Let's move on to septic shock. Sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. Neonatal sepsis, there are two groups. One, early onset sepsis. That means sepsis happening within 3 days. If the sepsis happens after 3 days, that is called late onset sepsis. The pathogens are very different from early onset sepsis to late onset sepsis. Early onset sepsis, the pathogens commonly come from maternal genital tract, like group A, group B streptococcus, E. coli, and listeria. In late onset sepsis, the organism can be gram-positive, gram-negative, or fungus. Gram-positive pathogens such as coag-negative staph, Staph aureus, and group B streptococcus. Gram-negative pathogens are E. coli, enterobacteria, pseudomonas, Candida albicans, especially in patients with very low birth weight neonates. There are three kinds of shock. One is compensated, means the body works to overcome developing hypotension and hypoperfusion. So the blood pressure is maintained, but these patients tend to have other evidence of shock like increased heart rate, lethargy, poor feeding, so on and so forth. In uncompensated shock, the hypotension becomes obvious. So the defense mechanism unable to compensate. So you will have hypotension and evidence of poor perfusion in the form of acidosis. Irreversible, that means the body unable to overcome the effects of the infection with multiple organ dysfunction will become manifest. This is called irreversible shock. In the warm shock or early shock, in those patients you will have vasodilation, reduced systemic vascular resistance, and increased cardiac output. On exam, these patients will have warm extremities, fever, tachycardia, and raised pulsation amplitude, and you will have a capillary refill like flash capillary refill. If you measure the blood pressure, you will have big pulse pressure with low diastolic blood pressure. Cold shock, when the warm shock is not addressed right, then it progresses into peripheral vasoconstriction and increased systemic vascular resistance. An exam, they will have a cold, clammy extremities, weak pulses, and there is a central and peripheral temperature differential you will see, delayed capillary flow time, and also these patients will have oliguria, decreased urine output. This is an algorithm how to approach patient with neonatal septic shock. Number one, recognize the initial signs of shock. Then immediately give a fluid resuscitation. Recommended is 10 ml, 10 to 40 ml per kilo until the patient improves or hepatomegaly or respiratory distress appears. Correct hypoglycemia and hypocalcemia. Initiate prostaglandin infusion until the coexistence of ductal dependent heart disease is excluded, and start antibiotic therapy immediately. If the patient is refractory to fluids, then infuse dopamine. The first line recommended in neonate is dopamine followed by dovitamin. If the patient is still not responding, it is called refractory to fluids and dopamine and dovitamin, and we'll talk about what other things we need to do in subsequent slides. So neonatal septic shock can present with following signs and symptoms, like the patient newborns can have tachycardia, respiratory distress, poor feeding, poor tone, poor color, tachypnea, diarrhea, reduced perfusion, and often have maternal history of chorioamnionitis or prolonged rupture of membranes. One should differentiate the septic shock patient from cardiogenic shock by clinically looking at hepatomegaly, cyanosis, cardiac murmur, and differential upper and lower extremity blood pressure or pulses. And neonates with inborn errors of metabolism also can present like sepsis, but these patients will have hyperammonemia, hypoglycemia, or severe acidosis. So in those patients, appropriate lab tests should be obtained. So what do you need to do during the first hour of resuscitation? Like any other emergency, airway, breathing, circulations. Maintain the airway, provide oxygenation and ventilations. And second, restore and maintain the circulations. Make sure to reach the normal perfusion and blood pressure and maintain threshold heart rate. The therapeutic endpoints of the first hour resuscitation or initial resuscitations are and bring back the capillary flow less than or equal to 2 seconds. Normal pulses, meaning there is no differential between peripheral and central pulses. Warm extremities. Urine output greater than 1 ml per kg per hour. Normal mental status. Normal blood pressure for age. Normal glucose and calcium concentrations. And the difference in preductal and postductal oxygen saturation less than 5% in 95% of saturation room air. These are all our therapeutic endpoints of initial resuscitation in newborn. So one should monitor temperature, preductal and postductal pulse oximetry, intra-arterial blood pressure, preferably using UAC, continuous EKG, blood pressure, arterial pH, urine output, glucose and ionized calcium concentration. So make sure airway is patent. Make sure the patient is oxygenated adequately and ventilation maintained. When to intubate, not based on the lab parameters, but look at the patients whether there is increased work of breathing or inadequate respiratory effort or severe hypoxemia in spite of your bag and mask ventilation. So the decision to intubate is mostly clinical. When you intubate, you should be prepared for volume loading and inotrope infusion because most of the sedative medications, even the positive pressure ventilation alone, can decrease the preload. They may need help with preload and inotropes. Pharmacology of intubation. Number one, make sure the patient tank is full, so adequate fluid resuscitation. And I typically give atropine to prevent bradycardia. And use analgesia very judiciously, like small 1 to 2 mg per kg, small aliquots. The current recommendation from Critical Care Medicine 2017, they discourage the use of ketamine, even though ketamine is widespreadly used in pediatric and adult septic shock. Etomidate has been used widely in patients with pre-cardiac and post-cardiac surgeries in neonates, but it is not desired medication in neonatal septic shock because of adrenal suppression. Other medications such as morphine, propofol, barbiturates, high-dose benzos, and dexmedetomidine, they are likely to cause hemodynamic instability, so they are not recommended or suggested to be used during intubation by the recent recommendations. Currently, they let you use atropine and fentanyl. Vascular access can be rapidly attained, and it's preferred to have UA and UVC. IO access, particularly in preterm newborns, is not the preferred route of drug administration, which is a little deviant from, not little, definite deviance from pediatric and adult septic shock. There, one can use IO right away. How to do fluid resuscitation? Fluid boluses 10 ml per kg can be administered, and watch for hepatomegaly and increased work of breathing when you do that. Our therapeutic endpoints are improving perfusions, not to certain ml per kilogram, so keep that in mind. Up to 60 ml per kg may be required in the first hour. You don't have to give all 60 ml per kg. Fluid should be infused with the goal of attaining normal perfusion and blood pressure, not the specific ml per kilogram. While you're resuscitating the child, the patient newborn needs to be on D10 containing isotonic IV fluid solution run at maintenance rate so that the patient will not get into hypoglycemic episodes. The antibiotics depends on whether the patient has early onset sepsis or late onset sepsis. Current recommendation for early onset sepsis is AMP and GENT. Late onset sepsis, the recommendations, one can use semi-synthetic penicillins like axicillin, nafcillin, along with aminoglycoside. If meningitis is suspected, one can use third generation cephalosporins. I personally use cefepime along with ampicillin. If you suspect gram-negative, use pip/tazo, carbapenem, or cefepime. Empiric therapy should be re-evaluated in 48 hours. When the pathogen is isolated, the antibiotic therapy needs to be de-escalated and use the narrow spectrum antibiotics. And antibiotics should be discontinued if the neonate has improved and systemic cultures are sterile. We already did the airway, fluid resuscitation, and antibiotic hemodynamic support. This all no need to be done in a sequential fashion. Most of the time, all happens simultaneously. Patients with severe shock uniformly need vasoactive agents. Dopamine is a first-line agent, but one needs to remember in high doses, it increases pulmonary vascular resistance. Oftentimes, the children need dopamine at low dosage, less than 8 mg per kg per minute, along with dobutamine up to 10 mg per kg per minute. If the patient failed to respond, one can start using epinephrine in the dose of 0.05 to 0.3 mg per kg per minute. Pulmonary hypertension is more common in children or neonates, so hyperoxygenate initially with 100% oxygen. Metabolic alkalinizations can be done using bicarbonate and tromethamine, unless otherwise inhaled nitric oxide is available right away. Sometimes one can use mild hyperventilations by bringing down the CO2, thus alkalinization. Alkalinization causes reduction in pulmonary vascular resistance along with increased oxygenation. Inhaled nitric oxide should be administered as a first treatment when it is available. Typically, it works between 20 to 40 ppm. Backup therapies include milrinone and inhaled iloprost. that is inhaled prostaglandins. When there is a poor left ventricular function with a normal BP, nitrous or vasodilators or type 3 PDE1s to epinephrine can be used. Otherwise, milrinone or epinephrine can be used. But whenever you use the vasodilators, make sure you are watching for low blood pressure and cardiac arrhythmias. If you suspect thyroid insufficiency, one can use triiodothyronine. If the patient did not respond to dopamine, dobutamine, epinephrine, then next line of treatment is norepinephrine for refractory hypotension to maintain a CVO2 more than 70%. Hydrocortisone can be added for catecholamine resistant shock and also for adrenal insufficiency that is defined by peak cortisol level after ACTH less than 18 or basal cortisol less than 4 or basal cortisol less than 18 with the need for inotropic support. So in those conditions, hydrocortisone can be used as an adjuvant. When you use umbilical catheterization, please do not use UAC more than 5 days and UVC more than 14 days. Use low dose heparin with a dose of 0.25 to 1 unit per ml should be added to the fluid so that it won't get clogged. When you use a PICC, like peripherally inserted percutaneous central venous catheter, use a prophylactic use of heparin to keep the lumen patent so that it can be used for longer term. If the patient still have refractory shock, one should rule out PDA-dependent lesions, inborn errors of metabolism, pericardial effusion, pneumothorax, ongoing blood loss, hypoadrenalism, and hypothyroidism. ECMO plays a significant role in neonatal shock because survival rate in newborn sepsis is more than 80%, much better than pediatric and adult septic shock or ECMO survival rates. The indication for ECMO in neonate is refractory shock or PaO2 less than 40 millimeter of mercury. The most common ECMO done in neonatal septic shock is VV ECMO. As you all know, there are two kinds of ECMO. One is VV ECMO or VA ECMO. VV ECMO means venous ECMO. So input comes from central vein and it goes back to another vein. VA, the blood comes out of artery and goes into the venous system. This is called VA. When we do a VV ECMO, hemodynamics should be treated with inotropic under vasopressor therapy or converted into VA ECMO if the medication is not alone enough. When you do a VV ECMO for a patient with pulmonary hypertension induced right ventricular failure, it unloads the right ventricle, it reduces septal bowing, and improves the left ventricular output. VA ECMO is considered when there is a primary left ventricle or biventricular failure refractory to inotropic and vasodilator support. Inotropic requirements can diminish when VA ECMO is used, but it can persist. Make sure the calcium concentration should be measured and normalized. If there is inadequate urine output or the fluid overload is more than 10%, so CRRT must be performed along with ECMO circuit. This concludes seminar on neonatal shock. Please leave your comments, and if you like it, and share it with others. The others could be medical students, postgraduate students, residents, and those who are interested in pursuing their academic career. Thank you so much for listening, and look forward to hearing from you. And we do give seminars every Sunday on important medical topics. Thank you again.